Good evening, everybody. So, I'd like to welcome you all to this Keele University inaugural lecture series. I think this is the first inaugural lecture from the faculty for some time, and so it's really good to see so many of Will's family, friends and colleagues here. As I've just said to Will, this is probably the only time in your entire life that you've got a captive audience where people want to hear what you say, so I hope Will gets to enjoy every single moment of this. So people who don't know, Keele University was established in 1949, so this is our 75th year, and we're very proud of that fact. Established by Lord Lindsay with the vision that Keele would always be different and approach things differently, and we're very proud that 75 years on that tradition still continues. My name is Christian Mallon, and I've got the huge privilege of being the Executive Dean of the Faculty of Medicine and Health Sciences. I've got very vivid memories, Will, of my inaugural lecture at Keele, which I desperately tried to get out of. So it's a real pleasure to be able to introduce you tonight into the hot seat rather than it being somebody else. Now, for people who don't know, Will was born in Stoke, so a local lad who's come back to his roots, where his family had a veterinary practice for more than 30 years. Both his grandfather and his great-grandfather were local medics working in North Staffordshire, so a real pedigree in the profession in the area. He's married to Fiona and has 3 young children, Arthur, Edith and Thomas, who are at home waiting anxiously for Dad to get back so they can have a party, which is exactly what should be happening for children. So Will's got an interest in global health, having worked on projects in Nepal and Malawi, amongst other places, focusing on cervical screening and maternal sepsis. He previously worked in Birmingham as a research fellow at the WHO Collaborating Centre for Global Women's Health, so a really prestigious role that really gives a strong grounding in research. He continues to collaborate with colleagues on postpartum hemorrhage, maternal sepsis, and maternal digital solutions, both in the UK and internationally. He's published more than 50 peer-reviewed papers and secured more than £3.5 million in grant funding, so very impressive track record already. Professor Parry-Smith, as now we need to call him, sits on the NIHR Midlands Patient Safety Research Collaboration Board and is the Royal College of Obstetricians and Gynaecologists Council member for the West Midlands. He leads the implementation team for the NIHR-funded Obstetric Bleeding Study UK and is chair of the Midlands Secure Data Environment Advisory Committee for Research. His clinical work is based at the Shrewsbury and Telford Hospital, where he's been committed to nurturing and growing a really strong research environment, really trying to get that department elevated and the rest of the hospital so they compete nationally and internationally. He's got a special interest in gynecological oncology, robotic surgery, colposcopy and intrapartum care, which is quite an unusual combination. His clinical work covers all aspects of general gynecology and acute obstetric care. So it's a great pleasure to welcome Professor Will Parry-Smith up so we can hear his inaugural lecture tonight. Welcome, Will.
Thank you very much, Christian. Such a lovely introduction. I might as well sit down now. You've summarised beautifully most of the first few slides. So it's lovely to be here in Keele. I'm going to detain you for about 40 minutes. The advice I had, which I'm sticking to religiously, is a third about yourself, which Fiona, my wife, said will be straightforward for you. A third about what you've done, again, straightforward for you, and a third about what you're going to do, which is probably the harder bit and took up more of my time when preparing this talk. So, how did I get there? What am I going to focus on? And how am I going to do it? I thought is how I would structure this. So, let's kick off. How did I get here? Well, it's a reasonable question for an obstetrician to pose. And we've just heard, I got here by dint of standing on the shoulders of the matriarchs in our family, but also this slide I put in, a 4th generation of medics, both human or animal, in the Midlands. And for my Sri Lankan colleagues in the audience who know this only too well, being an 8th Sinhalese, my great-grandfather came over from Sri Lanka to read medicine and at Cambridge, and then practiced in Tunstall. A man who did all his surgical exams, but was told, you can't practice as a surgeon in Birmingham because we don't have surgeons who are Sri Lankan in Birmingham in the 1930s. So, given this talk is on inequality, diversity and inclusion, that approach that happened nearly 100 years ago, I think is one that's impacted how we think as a family about diversity and inclusion for generations. My grandfather practiced in the West Midlands, and father, as we've heard, in North Staffordshire. There are friends of the family who were saved in mining disasters in Torque pits in the 1930s by my great-grandfather. So it's lovely to be back in North Staffordshire, an area both of pottery and mining that's impacted the community locally here and continues to do so in quite adverse ways. So how did I get here? Well, for those of you who are in the audience who are colleagues from Stoke, this is the now knocked down maternity unit in North Staffordshire, where I was born, along with my twin brother, who couldn't be here this evening because he's in court, or was earlier in the day, on behalf of his clients, he tells me. So I think this is, you'll forgive the rather pretentious slide, I'm sure. So educated in Stone, then Shropshire at Packwood, followed by that well-known bastion of inequality, diversity and inclusion, Eton College, and then Imperial College, another bastion of inclusion, and then finally had proper education at Birmingham and the RCOG. I work at Shrewsbury and Telford clinically, and I'm delighted to be here at Keele as a clinical academic. It's obligatory to have some photos. You can see there the three children, Arthur, Edie and Thomas. It's hard to get them all to stand still, and so I have to literally line them up against a wall to take photos. Arthur enjoyed coming up here for the Keele Open Day in the summer, and clearly enjoyed dressing up as a paramedic, and Edie clearly already got her CPR sorted out as well. So they're the three of them, and then you can see here the better-looking younger brother, Edward, on the left there, me, much better-looking wife, sister-in-law Emma, who's kindly in the audience, taken time off from her busy clinical oncology practice, my brother, twin brother Ben, Amanda and Philip are in the audience, and there's a photo of me in about 1920. This is my twin brother in the middle there, not me, but I thought I'd put that in because I was flicking through the photos and was a little confused when I saw it first of all. So that's Ben. He's a divorce lawyer in London. Fiona, who is, without question, the glue that holds the whole family together, the person who supports me through all of my shenanigans, and is here this evening. You can see it's not always been roses, because as some of you know, I broke my neck 3 years ago, very nearly paralysing myself. It was Fiona who snuck in her physio uniform to bypass the matron on the ward in order to check that I was actually okay. So I think that was quite a turning point for me. I was merrily enjoying myself doing clinical work, and then that gave me 6 months off to entertain myself, and that's when I rekindled some academic pretensions that's probably landed me here, because I started collaborating with colleagues on postpartum hemorrhage work, put a few grants in, and was moderately successful. And so in many ways, one of life's great upsets, breaking my neck, allowed me to have time to start to focus on some academic research. And then I thought, this is quite good fun, and so I carried on doing it. I thought you'd enjoy seeing pictures of when I was thinner. I should have narrowed it on the cropping tool a little bit. But I did my medicine at Imperial College, an undergraduate and BSc at Imperial, and then I came to the Midlands. I walked onto the ward and saw Fiona, and I've stayed ever since. And you can see I worked mainly in the Black Country, Stoke, Wolverhampton, Walsall, Shrewsbury, and in Birmingham as well. And that was my last day as a registrar in Stoke. They pulled the emergency buzzer and told me there was a shoulder dystocia in the room, so I went running to the room, and then I was covered in methylene blue and various other substances, I think Hipitane. And then what do I get up to at the moment? So it's this is certainly one of the things I enjoy doing, being a professor up in Kiel. But I think Christian has summarised that for you already. Gynecologist and colposcopist, obstetrician, and robotic gynecologist. Makes me sound rather inelegant with my movements, but it's a robot that does the surgery, controlled by me. Research and Innovation Director at Shrewsbury and Telford, and that's a role that has allowed me to improve Shrewsbury and Telford's research. When I started 3.5 years ago at Shrewsbury and Telford, it was a department that was really good at doing portfolio studies, and now we're nurturing our own clinical research projects, improving our budget such that we're now making a profit every year, and we run 77 clinical trials across 16 specialties in Shrewsbury and Telford now, from a slightly lower base, and so taking that organisation and improving its research and improving the delivery and clinician delivery of that research locally has been a real joy in the last 3 years for me. When I went to Shrewsbury and Telford, people said to me, "Are you sure you want to go to Shrewsbury and Telford?" And I said, "I absolutely want to go there, because this is going to be an organisation that's going to go from a period of great difficulty and then will transform." And we have transformed as an organisation, admittedly with a significant amount of money, but it's not money that transforms organisations by and large. It's the culture, it's the people, and it's the team that we put together nearly 5 years ago now that have really transformed our maternity improvement program, and we've now gone from CQC, I don't forget what the rating was at the time, I think it was somewhere like terrible, to good. And to go take an organisation from a low base to CQC good has been a real journey for all of us. There's too many people in the room to pay tribute to, but the clinical team, we really lent into doing that. And that has then sparked further research and innovation. So I think it's important that you take a view about why you do something and understand what it is that you want to achieve. And part of that guiding principle is why I've chosen to talk about levelling up women's healthcare, because you need to do something that interests you, and then it's not really work, it's actually a real joy to start to motivate teams and improve people's healthcare through doing what you enjoy. I have advised NHS improvement. I enjoy doing the parliamentary ombudsman work because you can always find worse off than yourself. I've recently been appointed as the research advisory chair to the West Midlands Secure Data Environment. I've got the small task of putting that group together now and actually executing it, but that'll be fun for the new year, and then other projects, as you can see there. So you're supposed to talk about what research impact you have, and I thought, oh no, what research impact have I had? There's a great tool, I'd encourage all of you to have a look at it, called Policy Profiles by SAGE, and you just put your name in there, and it tells you how many times your research has been used. So I did that late last night, and I was pleased to see that the research I've done has been cited in more than 25 policy documents across the world. Interestingly, the dot in the middle there that looks like it's in some long-forgotten British territory is in fact Geneva, but they've sort of misplaced it. I did wonder what small island nation were obsessed by my research. And I'm going to canter through very briefly where the research ends up. And again, this is an example of just taking a problem that interests you, looking at it, and then writing about it, and all of a sudden people then find it interesting enough to cite in their guidance. So, intrapartum care, nice, WHO cervical screening, fetal monitoring in labour, another WHO guidance on LETs and colposcopy, some postnatal care, and then work that we did in Birmingham, which took a lot of time and effort, mentored by Ari, who's in the audience, systematic review looking at postpartum hemorrhage, which I've double counted here. Another WHO guidance on cervical precancer lesions. And then my favourite one of the bunch, I was getting quite exercised in about 2016 about people's behaviour and communication with each other, and we decided we'd look into that, and all of a sudden you can find in New South Wales that people are taking interest in that work as well. So it's curious where these things end up. So what am I going to focus on? And this is now, so that's the first third done. You'll be relieved to know about me. Why is equality and diversity in research important? So we know that it's key to improve the relevance and quality of our research, and we know that because when you think about it, it's self-evident that if you include everybody who has disease in your research, you might then develop tools to help all patients, not just the ones who happen to get involved in research. So you need to actively decide to engage in making sure that your patients represent the population that we serve. And you think that is a self-evident comment, but it's clear when you look at the makeup of clinical trials, where those clinical trials take place, they tend to be focused on units that are tertiary centres in wealthy university towns, which is not where the disease of the population is. That tends to be in more rural, coastal areas or northern, more northern towns with less affluence. So most of the research takes place in the Golden Triangle, Cambridge, Oxford, and London, but most of the disease happens outside of that area. And that, for me, is what's going to change how I think, how I act, and what we're going to do over the next 5 years, because that is not right and it's not good enough. So the NIHR clearly say that we need to start to have these 5 columns in our research and the way that funding is arranged in the UK. And that's becoming a more inclusive funder, widening access, improving the talent pipeline, and I'll come back to the talent pipeline in a little bit, embedding evidence-based approaches in what we do, and collaborating widely. And I'll come back to collaborating as well. But these are the 5 areas that need to be focused on as we think about equality, diversity, and inclusion, and research as a whole. And why focus on this? We know that imbalances and inequities are associated with socioeconomic status, geographic location, and access to health and care. So we need to think outside of that triangle. I'm pleased to say that Keele is outside of that triangle. So is there a particular problem in maternity care? You would be amazed if I stood up here and said, no, there isn't. There is clearly a problem in maternity care. So the latest Embrace report, which takes all women who have disease in the UK every 3 years and looks at why women die, and has a team of experts centred in Oxford and Leicester who do that, advised by colleagues up and down the country. And if you're a black woman or an Asian woman, your risk of dying in pregnancy or the postnatal period is 3 times or twice as likely as a white woman. Pretty stark figures. And if you live in an area that is more deprived, you're twice as likely to die. And if you're a black woman who lives in a poor area or an Asian woman who lives in a poor area, that means the odds are stacked against you. And that cannot be right. And you can see there that we seem to be getting really not any better. We may even be getting slightly worse as time goes on, which is quite sobering when you think of the amount of money, time and investment that's put into healthcare and maternity in particular over the last nearly 20 years. We came down, and then from about 2014 you can see things are beginning to tick upwards, and I suspect the next report will show an even higher mortality rate, which is worrying and concerning, and part of the reason the government has started to decide to take this maternity problem and seriously examine it and seriously resource it. I put this one slide in now. I know we're a diverse audience, but it's fairly easy to summarize in the little red brackets there. Effectively, if you are particularly young or particularly old when you have a baby, you are more likely to die. I think our great-grandparents knew that, but it's quite stark to see it in black and white. So if you're a young mum or I always hesitate when talking to patients clinically as well, a slightly older mum, you can see there that you are more likely to run into difficulty. And the Embrace report quite clearly stated that if you're over 35 years old and having your first baby, you're at higher risk of death. So we need to start to communicate with women and girls. Most of the education that school children get regarding fertility and is focused on contraception. Do not get pregnant. This is how you must have safe sex. This is what you must do. No one ever talks really about children except for Professor Balin and his team now running that through a government program. We need to talk about when you should conceive and when you need to start a family, because we can see that that also mitigates your risk. If you are more deprived, from a more deprived income or area of the UK, you can see that you have a much higher rate of dying as well, and the same for Asian and black ethnicity. We don't quite understand why Chinese ethnicity seems to confer a benefit. Something we can think about. And you can see there the same data just displayed again over time to show that mortality is ticking upwards as the years roll on rather than downward. And you can see there if you're from a socioeconomic deprivation group that's more deprived, you're more likely to die than if you're from a least deprived area. So yes, there is a problem in maternity. So that's maternity. Since we're talking about women's healthcare, I thought I'd share with you some of the data for gynecology. So, I've done enough talking. How many women are waiting past 18 weeks for gynecology treatment in England currently? Give me a guess. 500,000? 750,000? So that's the amount of people. I've not been to either of these places, but there's a great tool online that will tell you the size of crowds. And so you're looking at the moment at 266,000 women, nearly 267,000, 100,000 women as of September, waiting for treatment more than 18 weeks. And 22,000, so the O2 Arena, I thought we'd be looking at a crowd similar to this evening. We wouldn't need to do the crowdsource thing for this bespoke audience. But 22,000 women waiting in the UK more than a year for their surgery. So we have a problem in gynecology as well. And there's a great report, Left for Too Long, and that talks about why this might be. Staffing is a problem. The use of the word benign to describe gynecological conditions is not a helpful term when we think about levelling up women's healthcare. There's nothing benign about having terrible pelvic pain. There's nothing benign about having to have a blood transfusion because your periods are too heavy. So we need to get away from the term benign. Now, I do oncology work, so I don't think we need to use the term malignant, but I think we need to think about how we speak about the problems that our patients have, and using the word benign minimizes suffering, which we need to avoid if we're going to start to change the way that we practice and start to resource the problem. Because 77% of women report an inability to work or take part in social activities, and they feel dismissed, that they don't really matter, and they report feeling ignored and their mental health getting worse. So levelling up women's healthcare affects women, it affects their family, it affects their economic output, their happiness, and again, we need to think about why it is that we allow this to occur for women, and we probably wouldn't let it occur for men. I promised Fiona I wouldn't say this, but I think there's a latent misogyny in healthcare. And I know this might go out on YouTube at the risk of being cancelled. I think there is a latent misogyny. And I think this slide really sums up why that's the case. Every year, there's a winter bed crisis, and every year in gynecology, it's the first ward to close. If there's a bed crisis, it's always the gynecology ward that gets closed. And I know, and gynecologists up and down the country will tell you, that they don't have access to theatres in the same way that our general surgical colleagues do as well. A couple of general surgical and other surgical colleagues in the audience. And that's not to say that we just need to have a degree of recognising what bias there might be. And there's various suggestions about how we might do that. Women's health hubs might help improving the way that we triage patients, improving advice and guidance, and probably a public health thinking about the way we align service, sexual and reproductive health through primary and secondary care, and throughout the whole system. We probably need a more joined-up, systems-wide approach to tackling this problem. Just putting me on a Saturday afternoon to grind through a backlog of patients, while lucrative, isn't going to necessarily help. Expensive, rather. So how am I going to do it? I am not going to do it by doing Saturday and Sunday lists. It's not going to work. We need to take a more holistic, joined-up way of thinking about the entire problem. And so one of the first things I thought we ought to do is to try and work out, and with a particular interest in postpartum hemorrhage, to try and work out why there seems to be a higher risk of bleeding if you're not white. And so Amy, who's our doctoral student at Shrewsbury and Telford and Keele, I said to her, one breezy supervision, I think we should look at this, Amy. And then that turned into about nearly 18 months of hard work from the whole team. And I'll share with you some of the results that we are going to submit to publication in the next week or so. So we looked at studies from across the world in North America, Europe, and other parts of the world, and particularly the Antipodes. And you can see there that we looked from 1979 to 2021 with over 165 million women and nearly 3 million episodes of postpartum hemorrhage. So this is a large meta-analysis of patients. And you can see on the next slide the results. We obviously conducted this in a fairly standard manner. And you can see that if you're black, you're 1.17 times more likely to bleed, Asian 1.3, or Hispanic 1.19, and a minority ethnic group 1.15. So we can see, and this is the nice slide, effectively you just don't want the lozenge at the bottom there to hit the 1. And what you can see there is if you look at all of those studies together, you are more likely to bleed in this particular analysis if you're black than white. Across lots of different countries, lots of different populations, it holds true. And we repeated the same work for other ethnic groups, and we saw the same effect. So we know there's a problem with postpartum hemorrhage, and we have nicely described what that problem is. We then need to think about, well, what is it that we need to do? Because women having postpartum hemorrhage is a serious issue globally and a leading cause of death for women. It's a problem that can be mitigated in the UK effectively by having access to blood transfusions and intensive care units, but in other parts of the world where that's not available, women regularly die. Women still die in the UK, but we can mitigate that risk. But it still has effects on their well-being, ITU stay, postpartum depression is linked to having had a postpartum hemorrhage. So the OBS UK study, which I'm co-applicant for, co-investigator for rather, and lead the implementation team, has a very long title that we shortened to OBS UK, and quite an unusually long title, so hence we've gone for OBS UK. And the funder stipulated that we had to recruit people to the trial who looked like the rest of the UK. And this is the first time that they've done that, and so we had to think about how we made sure that our research aligned with this ambition, and you now understand why that ambition is so important. And so we've just published this work which looked at creating a dashboard and mapping the whole of the UK in terms of equality, diversity and inclusion metrics using census data. And then we made sure that our clinical trial sites looked like the UK. And so what people normally do is they ring up their friends and they say, I've got my NIHR funding, can you do my trial? And you say, yes, of course, and then you're a trial site. And that's been done for a long time. We need to move away from that, and we need to start to use this tool so that other studies reflect the population. And so this is a very easy win. It's quite a neat and, if I dare say so myself, elegant way to do it. So we've now developed a tool that selects maternity units that represent the UK. And we did that by using nationally available data. It won't surprise you to learn that England, Scotland, Wales, and Northern Ireland all collect the data differently. So harmonising the way that we collect data is probably another outcome we need to start to think about, because you can't very easily compare one region of the country to another particularly well, but you certainly can't look at one principality or country, in the case of Scotland and Northern Ireland, to the UK, to the England rather. So we need to start to harmonise the way we collect data so we can understand what it is that we're doing. And so we mapped all of the UK, and then you can see there we looked at ethnicity and deprivation. You can see there's roughly 674,000 births in the UK a year. And that then allowed us to ask sites to take part in the study. We had 36 sites to select, and 50 sites were interested to be part of the study, and so we were able to select sites based on what they looked like. And Shrewsbury and Telford, you could see there that we're part of the trial, and you can see how our data looks there. Not particularly diverse ethnically, but certainly plenty of deprivation. And you can then take on the left-hand side there, the 36 sites, which we made sure were spread across the country, and compare that to the UK, and you can see there that the sites match the UK. We didn't get anybody in Wales because the study had already been done in Wales, and we didn't get anybody in the south-west of the country because of the exclusion criteria for the study. You had to have a certain not to have a certain piece of kit on labour ward, and most of the southwest had taken the Welsh lead and were doing the blood testing that we didn't want them to do. So we excluded effectively the southwest. And so this is the first time in the UK that we've compiled this data, and we've demonstrated a novel way to ensure that we have trials that represent the UK. And so these small steps will start to mean that our research begins to serve all women. So the last couple of minutes, I'm going to tell you what we're going to do next. So this is being announced tomorrow. So I am breaking the embargo, but those of you who know me well will not be surprised about that. Many people already know this. So there are 18 universities in the UK which are part of a maternity collaboration. Each one is regionally based, and Jote, who's in the audience, and colleagues and I basically put together a collaboration in the West Midlands, Birmingham, Keele, Warwick and Birmingham City Council. It was my first foray, really, into trying to get a load of academics to agree with each other. It required all the tact and diplomacy that I was taught at Eton, and the ability to get people to put their egos to one side and do exactly what I asked them to do. And we got there. And I'm delighted to say that Keele are a key partner of this maternity inequalities collaboration. £50 million over 5 years. So this is our version of the space race in maternity inequalities. And I'm delighted that Keele, and delighted that I'm part of that, and we will do great things in terms of capacity building, building a pipeline of new researchers, having multi-professional teams, multidisciplinary teams. I do think, I love obstetrics and gynecology, but I do think if I had my time again, I might become a public health doctor, because I think they have all the fun. The way they think about the way the system fits together, the drivers to care, the barriers to care, they think in a very different way to us clinicians who cut things out. And I think the COVID pandemic has taught us that actually our public health colleagues should really be cherished. They do occasionally need clinicians who get their hands dirty to show them the way when they get a little hung up on minutiae, but actually a public health-based approach to maternity inequalities across sectors, using charity partners, using the local government, listening to women, engaging with women from across the West Midlands to really refine how we're going to do this, make sure that we're asking the right questions and making sure the solutions we come up with are correctly focused, I think will land us on the moon. And that's being launched in April of 2025. And you can see there, again, it's spread nicely up and down the country. And this means the government are now taking seriously that data. You can see it, the moment you start collecting data, displaying problems over time, showing that inequalities exist, both in terms of ethnicity and deprivation, and build a narrative, eventually you begin to change hearts and minds. Because actually everything we do as clinicians and academics needs political will, lobbying and policy change in order that we can improve the lives of women, babies and children across the country. And I think, if nothing else, I think the last few years has taught me that we need to work as a team across healthcare, across industry, across the third sector, and ensuring government and stakeholder engagement to change what we do. I can deliver as many babies as I want by cesarean section or forceps delivery, but I'm not going to change the dial unless we change the drivers that have led to the poor outcome before I snatch them from disaster. It saddens me as an obstetrician to say that, but I think we need to think more broadly about what it is that we're doing. So to end, Keele is part of the solution. We've got a team together across the UK from all disciplines, all areas, and I think we will commit to reducing maternity disparities, and we've got the money and expertise to do that. I'm looking forward to taking part in it. Final vote of thanks, Amy Elsmore, Amrit Dada and Neil Coburn, who are the 3 doctoral students. I do genuinely have the honour to supervise. 2 of them in the audience, Amrit isn't, I'll talk to him about that later. But it's a real honour to work with them, and I've got my 2 academic mentors in the audience, Ari and Krish. Learning from them has been immensely helpful, and the way that they think and the support they've given me has been invaluable. Jyot Chandan, who's in the audience as well, and colleagues from the maternity improvement team, and then clinical colleagues listed there who've helped as I go along my training, and colleagues to this day, and the late Charles Redman, who sadly died and was really looking forward to being here. was a great surgical mentor. The R&I team at Shrewsbury and Telford, Joe, who's in the audience, and the team there have been hugely helpful, and of course Fiona and the whole Parry-Smith gang. So, there we are. Maternity inequalities, it's a problem. We've got a solution, and I'll leave you to ask me some questions. Thank you very much.